So, welcome here to our Mars webinar. I welcome everyone here. Today's topic is a wonderful and actually really trendy topic. Tonight we are talking about the potential impact of the 2020 US presidential election on global healthcare pricing. The election that actually just turned, to become final after a long of denying of Donald Trump, and now we got hopefully soon Joe Biden as the next president of the United States. And tonight we have that wonderful Mars seminar, but we are not alone. Tonight we have two wonderful guests from our colleagues from the US, from New York area, Karen Sandman and Anna Forsyth. Welcome you especially here. To our Mars webinar. We want to talk about that tonight. As we know, Mars is a consultant agency, and we are specialized for reimbursement in pricing and health economics in the DACH region. So we every questions with pricing and reimbursement for Germany, Austria, and Switzerland, also health economics, or submissions to those authorities like the GBA, the Federal Joint Committee, also with the new DIGA application to the BfArM, the Swiss BAG, or the Hauptverband, the Austrian Hauptverband. We are happy to help you with these applications. And also we do what we have in our name. We have also the pricing strategy, and we have something really cool now coming up. So please prepare for our virtual boot camps. So we have these nice VR glasses, and we show you this also in one of the next lessons, a little bit more about that, how we can prepare you the best virtual reality preparation for your price negotiation to get an optimal outcome. Okay, and then we have our guests from tonight is the Karen Sandman and Anna Forsyth from the Purple Squirrel Economics. Purple Squirrel Economics is, as we are a consulting agency, but they are much broader. They do actually a whole global evidence packages for you, and feel free to contact them also after the webinar. You can also find them over our website, and they have HTA evidence generation. They do the whole health economics, analytics and calculations. They do the value communications or core value dossiers and stuff, value access planning and strategy, and also develop for you health economics models and of course HTA submissions. And I want to also encourage you about to ask questions, so you can have the questions here right in the chat, or you use the Zoom question answers function here to raise your questions or comments. And as always, slides will be provided afterwards, and the video will be published on our website. And if you just missed that webinar, you want to rewatch it, just go on our webpage and www.marketaccess-pricingstrategy.de, and then we have here that banner webinars, and then you can rewatch there the webinar also and register for the next ones. Okay, now tonight we want to talk about that 2020 US presidential elections and its potential impact on global health care pricing. And I want to welcome first my boss, the CEO of Market Access and Pricing Strategy, Stefan Walzer. Welcome, Stefan.
Thank you very much, as always, for the introduction. Also from my side, a big welcome to Karen and Anna. I think it's a great pleasure to have you here, and also to listen basically to you what is now going on as well in the US, and then I think afterwards to also discuss how this might have a potential impact then on the global, especially the healthcare pricing there.
Okay.
So I will this time not have too many words. So look, you can go on the next slide.
Yeah, I just want to introduce Karen again. Karen Sandman, she has a PhD from the MIT, and she's the senior partner of the Purple Squirrel's Economics Agency. She's the head of value and evidence communication. And and also we have here the CEO and the managing partner of the Purple Health Economics, of the Purple Squirrel Health Economics Agency, Anna Forsyth. Based in New York, she's the head also of the evidence generation, and with a PhD and an MBA. And the best title I thought is that you're now a adjunct professor for health economics at the Long Island University. So, Professor Forsyth, welcome. Okay, now Stefan, the floor is yours.
Yes, thank you. Just, of course, I think that was obviously missing, I think, the quick introduction. So just, I think you can directly jump on the next slide, Lutz. I think at the end of the day, I think the very first start, obviously, of that kind of discussion, the presentation is clearly, I mean, what we also just had briefly before the start of the webinar, the outcome of the US election, right? I mean, there was quite a bit of uncertainty, and I think not only in the US, but I think also across across the different countries. I think everybody was really following closely what is happening and what was happening, especially also with the different kind of votes and the turnaround basically as well. And finally, I think we have now, I think, or you have now as well, a final winner. I think Joe Biden might be, and hopefully will be, the next kind of president with 306 votes versus 232, which have been directed to Donald Trump. I think that's basically already what I would say. I think, look, the next one is a very clear and short kind of introduction to Joe Biden's vision on healthcare. Before we then move over to our US colleagues, they will as well go then into further details what this kind of idea and the direction and vision might have just for the US. I think that will be a very good kind of basis before I would then come back into the game, let's say at the very end again, and try to foresee or maybe put a couple of scenarios together how this could potentially then impact the global healthcare pricing.
It was great being part of the first Democratic debate in Miami. The question was asked whether we support eliminating private health insurance. Some said yes, I said absolutely not. I believe we have to protect and build on Obamacare. That's why I proposed adding a public option to Obamacare as the best way to lower costs and cover everyone. I understand the appeal of Medicare for all, but folks supporting it should be clear that it means getting rid of Obamacare. And I'm not for that. I was very proud the day I stood there with Barack Obama and he signed that legislation. Never before had anyone ever been able to do that in the White House. 20 million Americans gained coverage. Over 100 million with pre-existing conditions finally got protection. And most importantly, peace of mind. You know, I know how hard it is to get that passed. I watched it. Starting over makes no sense to me at all. I knew the Republicans would do everything in their power to repeal Obamacare. They still are. But I'm surprised that so many Democrats are running on getting rid of it. The Affordable Care Act was a historic achievement for President Obama. And if I'm elected president, I'm going to do everything in my power to protect it and build on it.
All right, so now we're all feeling inspired by that. We'll get into some of the impacts of how this election might look, both for the U.S. healthcare as well as how that might impact our neighbors around the world. So, as we've established, we now have a president-elect and a vice president-elect. So Biden and Harris have basically been declared the winners. As you probably have heard, there's a little bit of legal wrangling that still is going on, which is unlikely to change the outcome, but the next few months may be a little bit more chaotic than normal in terms of how these things go every 4 years. So one thing as we get into, how does the presidential election impact what happens in healthcare. I think it's important for folks who are outside the US to remember that the president has certain powers, but they're not extreme. So we have the three branches of government. And so in the middle, the executive branch, that's the president, vice president, and the people that they appoint. And so they can certainly make a lot of decisions on their own. They can sign a lot of orders on their own. But ultimately, most things have to go through our legislative branch, so Senate and the House of Representatives, who pass the laws that actually make things happen. And we have the House of Representatives has a Democratic majority after this election. So they're very likely to work with Biden and Harris on moving forward the healthcare plans. The Senate, we don't know yet whether they have a Democratic or Republican majority. So after there's this election in the state of Georgia in January, we'll find out which party is holding the Senate power. And so then we'll know whether that's going to be a party that's likely to cooperate with Biden and Harris, or whether, you know, if the Senate continues to be Republican, then this is going to mean that maybe they're going to have to do some more compromising, work a little harder to convince people to move Biden forward. So that's just something to keep in mind when we talk about his plans. We have to remember that a Republican Senate could stop those plans from moving ahead, or might make them need to get a little bit more conservative in order to pass. And then meanwhile, on the other side, we have our Supreme Court. So if people believe a law to be unconstitutional, they can bring that to the courts to try to have it overturned. And that's something that in the US, the Republican Senate and other Republicans have been trying to overturn Obamacare for several years. And as you may have heard, there are several very vocal opponents now on the Supreme Court when it comes to the Affordable Care Act. So in addition to needing to have the cooperation of the legislative branch to move things forward, there's also the possibility that the court could overturn any healthcare legislation that they consider to be unconstitutional. So, you know, thankfully we don't have a dictator. We have a president who has to work with other branches of government. But that means that everything that we're talking about what Biden wants to do is just what Biden wants to do. It isn't necessarily what he will do. Okay, so with that being said, kind of, you know, there are a couple of key elements of what Biden and Harris are proposing regarding healthcare. So as that nice video just said, they really want to protect and build on the Affordable Care Act. They want to bring affordable quality healthcare to more people, not just to privileged people. They want to make our healthcare system less complex. And then this last bullet is where we'll spend a little more of the time, and that is they want to stand up to what they consider to be the abuse of power by prescription drug corporations. Okay, so in terms of what health insurance looks like for Americans, you know, obviously we do not have a single payer system. We don't even have a 2 or 3 payer system. We have many different payers in the US. So the main issue is that red box where there are a bunch of people who are uninsured. That is one of the biggest challenges in the US, because a lot of people have private insurance, either that's sponsored by their employer. So about half of Americans are on an employer-sponsored healthcare plan, either through themselves or through their spouse or parent. Other people might purchase an individual plan. That can be very expensive to do. And then if you're elderly, or if you're below the poverty line, or if you have some type of disability, then you would qualify for Medicare or Medicaid, which are state-sponsored and government-sponsored insurance programs. So you have the people who are employed and have health insurance through their work. You have people who qualify for government programs. But then there's a whole lot of other people who are either spending a lot of money on private insurance, or they simply can't afford insurance, and so they're uninsured, and they just have to hope that they don't get very sick. So the Affordable Care Act, actually, if we go to the next slide, the Affordable Care Act, which was passed in 2010, which is generally known as Obamacare, the goal of that was to address the challenges faced by the uninsured people and the people who are paying for their own insurance and simply, can't afford that and are being basically, impoverished by their health insurance premiums. So the goal was to increase the availability of affordable health insurance, to make it possible that people can pay a reasonable amount of money and have a good plan that will protect them and their family if they get sick. And so basically, the law provides consumers with some tax credits if they're between 1 and 4 times the federal poverty level. So, and then also expanding the reach of Medicaid so that you don't have to be far below the poverty level in order to qualify for Medicaid. Unfortunately, not all states have actually complied with that Medicaid expansion, so that part hasn't quite been fully completed yet. And then also to support innovative medical care to just lower the cost of healthcare generally, to recognize that there are areas where the US healthcare system could be run more efficiently and how to lower costs across the board. So that's what was passed in 2010 and what we still have now. And then there's the Biden-Harris proposal. So they want to build on that. So one is to just really increase that public option so that if people don't have great insurance through their employer, or if they're self-employed, or for whatever reason they want to be able to buy their own insurance, making that public option, which is sometimes called the exchanges, making that more affordable and making it more appealing. So one of the ways that they want to do that is to put a cap of how much money people are spending on a good health plan. So currently, it's about 9.86% of your income can go towards kind of a mid-level plan on these exchanges, and so that's kind of the cap that Obamacare says that you can pay in terms of insurance. So Biden's plan is to reduce that cap, so people would only spend a maximum of 8.5% of their income, and that would be for a higher level plan. So really trying to expand the access and reduce the amount that people are spending on their health insurance. So, and also continue with expanding that Medicaid coverage for low-income people. And so, yeah, I should say that, as he said in the video, there's no plan to get rid of private insurance. It's really just to make sure that people who need to buy insurance can do so in a way that's not going to cost 50% of their income. So some of the key things, that are there for access. So again, making the healthcare system less complex, trying to drive innovation and quality. So providing some incentives for healthcare systems to do things better, to have more competition so that they are more efficient and can lower costs. And a few things like there are certain ways that people end up with surprise bills that can really, spell financial ruin. So making sure that some of that is taken care of by reducing just the confusion and complexity in our healthcare system. And then also a lot about expanding the equity. So particularly initiatives about maternal mortality, gender discrimination, et cetera, expanding community health centers, mental health care parity. So across the board, just trying to reduce costs and expand access. And then, of course, the part that that probably most folks here are the most interested in, and that is about prescription drug prices. So there are 3 main approaches that the Biden plan cites about how to stand up to that abuse of power by prescription drug corporations, as they say. So the 2 that we'll talk about more in a few minutes are independent review boards and external reference pricing. But a couple of the other measures and protections that have been suggested are, first of all, to place a limit on drug price increases. And so, since so much of our healthcare is private, there's a limit to how much the government can control drug pricing. However, what they can say is that if a manufacturer wants to be covered in that Medicare and public option, that they can't increase prices beyond the general inflation rate, and to put tax penalties on manufacturers that do increase prices beyond what the inflation rate is. Another possibility is allowing consumers to import drugs from other countries once that supply has been established as safe. There's also taking away the tax deductions for advertising for pharma. And then lastly, really trying to improve the availability and supply and development of safe generic drugs. So those are a few of the sort of other strategies, and now we'll get into the two big ones. Okay, so drug price negotiation. Right now, you know, historically there hasn't been a lot of price control in the US for manufacturers. So the Biden plan introduces a few mechanisms to add some price control. So one is that Medicare would be able to negotiate with drug companies on prices. And then the other is kind of this, you know, if you have a novel drug that has no competition. So this actually doesn't apply to all drugs across the board. This is actually just situations where there's no competition. The Biden plan would establish an independent review board that can determine a reasonable price. And so how do you determine that reasonable price? And that would be the price that Medicare and the public option would pay. So private plans, they, you know, right now they would have to do their own negotiation with the manufacturer about price. But if that private plan agrees to participate in the Affordable Care individual insurance, like let people buy those plans for the reasonable rates, then they can also have that that reasonable price with a manufacturer as well. So that's kind of an incentive that, you know, this insurance plan can have the lower cost for drugs if they're providing consumers with the lower cost insurance. So so that reasonable price, if the drug is available outside the US, then that review board would recommend a price based on external reference pricing. If the drug is launching first in the US, then the board would conduct its own independent evaluation and decide what should be a reasonable price. Okay, so in terms of external reference pricing, so historically that hasn't been used in the US. Interestingly, both Trump and Biden have put forth their support of ERP. So actually President Trump just signed in September an executive order on lowering drug prices. And in the Biden plan also, he gets into external reference pricing. So both the executive order that Trump put forth as well as Biden's plan actually are pretty specific about ERP only being for kind of the, you know, most expensive, novel, new drugs with no competition, biologics. Whereas actually, for example, Bernie Sanders, he was going for something that would be much more broad reaching and using ERP across, you know, pretty much all branded drugs. So, you know, it's a more conservative approach to ERP. Yeah, so in terms of, you know, the fact that we don't have it right now, that leads to the US often being the first launch site. Typically our prices are about 3 or 4 times higher than in, for example, UK, Japan, and Canada. And, you know, in some cases even up to 70 times more. So ERP would be quite a different scenario. You know, one study had estimated that if Medicare alone adopted it, that Medicare could save over 70 billion. So that would be a big change if we went that route. So I'm going to turn it over to Anna now to talk about what this independent review board might look like.
I just want to be, I want to care about the time, but oops, and here my dog agrees. Right. The questions here are from the perspective of value and access people in pharma companies, what does that mean to us? And what does that mean to us getting reimbursement for our drugs, and US specifically, what can that mean for the global? I would like to bring the question of ICER because there was quite a bit of publications and press related to that independent review board may be ICER, that ICER is well positioned to take that role. And the question is whether you know a lot about ICER or not. And ICER does not stand for incremental cost effectiveness ratio, but I do think they did it on purpose, okay, so that we can all remember what they are. It is an independent organization, and it does exist now as an independent review board. But there are a lot of outstanding questions. First, ICER does not review all the drugs. They produce an agenda once a year, and that agenda is not always triggered only by what is coming to the launch. It is really a choice, and is no transparency really or clarity on what is going to appear on that agenda, and is a lot of anxiety among pharma colleagues that are our clients on, do you think, I'm always asked, what do you think? Do you think ICER is going to review us or not? And no one knows. So there is a question of whether ICER has capacity to really become that independent review board, because then they'd have to review a lot more drugs. Are they willing to establish a transparent and independent review process? Because although they do issue guidances and they do say that they follow a certain process, that process does not involve a manufacturer's dossier submission. So there is no chance at which a manufacturer is first notified and then a manufacturer has an ability to submit. It's all public revision. And as a matter of fact, the manufacturer cannot submit anything in confidence or any type of information, or there's no dossier. Is ICER going to get the authority by Biden administration to be that independent review board? Because in difference to NICE, who ICER tries to mimic, ICER does not have an authority. Their reports are out there and mostly are viewed as PR and not really used by anyone as a law or as an advice to how the so-called commissioning process is then done by private or public insurance. Public plans, well, public Medicaid and Medicare, the Center of Medicaid and Medicare, are not at all influenced by ICER, while the private plans, there is a question, is a lot of market research on the topic, who is influenced, and obviously the bigger plans are not. The bigger plans make their own decisions, but it does catch a lot of PR in the United States. There's questions about who will give ICER the budget, and it's not clear at all because they are a non-for-profit organization. They work on the grants, and whether this is going to be a sponsored organization. And finally, US is not well known for its wealth of health economic expertise. And I'm from the US, so as I may say, we do not have a lot of universities that are teaching health economics the way the universities in Europe or in Canada or in Australia are teaching health economics. We have very few that are teaching it that way and actually produce health economists at a speed that would be required if really we are going to put together a board that is going to follow a process. And now, regarding the specific methods of ICER, there's a lot of talk about, and that Biden referenced the German system, and he said he really likes the German system and he's going to use it. But we all know that ICER is not following the German system. ICER is following the UK, at least what they think they are following the UK, not fully. So the question still remains, is what is it going to do? Is it going to be a value-based or a quality-based assessment? There's not enough transparency in what ICER does. ICER often releases a draft protocol, and then by the time they release the final protocol, the terms of that protocol could be opposite of that initial protocol that just happened to their CAR-T assessment recently in multiple myeloma, where the population, the comparators, and what they plan to compare, who to who, which drug to which drug, completely changed between the draft and the final protocol. Sometimes the selection of the products changes. And so there's not really a lot of consistency or transparency about the ICER method. And outside of the US, as it's my understanding that there is a perception that ICER is independent and trying to follow the UK and bring that perspective to the US. But we are extremely far away from anything as established as any of the HTA bodies across Europe. Next slide, and I will just take very, very few minutes. I'm going to skip the other legislations. You're going to get the slides on that. I do want to touch on a topic that is, I believe, extremely important, which is COVID-19. And because regardless of who, well, we know who is the president, but regardless of whether Biden would put ahead and would be able to successfully have the legislation on the healthcare plan and have given ability for Medicaid or Medicare to negotiate prices. Regardless of that, this year we all experienced significant impact of COVID on US healthcare. And it is very specific to US in this case. It's different from other countries which have the national healthcare system. In this case, there is different impact on private and public payer system. In the world of the public, and it's all driven in both cases by unemployment. We do know that US unemployment reached very high in this year, and it's as of October this 2020, it's 6.9 million people that are unemployed. And the rise in unemployment is leading to more people going down to that into the uninsured world because they lose their insurance with losing their jobs, and they lose their income. So Medicaid enrollment increases drastically. It has increased drastically. Just 3 million new enrollees we have seen in just the first few months of COVID-19, and it has grown since then. So why is this happening? Because Medicaid enrolls those patients that are reaching the poverty line, and with unemployment so high, more and more people are reaching the poverty line. So more and more people are getting governmental sponsored insurance. They qualify. And if Biden gives the right to the governmental plans to negotiate prices, that would have a drastic impact. And the impact would be for the drug manufacturers that are planning to launch their new branded drugs next year. It would become extremely challenging, because if Medicaid can negotiate back and majority of their patient populations are going to be in the Medicaid, this would be very tough to get any drug on formulary, especially if that drug is expensive. Now, for the private payer, it's a different impact, but it still leads to the same challenges of getting anything on the formulary, because what is going to happen to the private payer, and it's already happening, they are losing their enrollment. Because again, people losing jobs, with that they are losing their participation in the employee-sponsored plans. What that means is that these private payers in the United States mostly make their formulary decision based on the budget impact analysis. So they spread the cost, the high costs of niche drugs, and every drug we all know now is a niche drug. So, and they spread the cost onto a per member, per month basis. I'm sure you've heard of PMPM. And they want that to PMPM to be pennies and very, very low, because they have a lot of enrollees and only a small portion of them would require that new, very expensive drug. But if they're losing their enrollees, they're losing their ability to spread the costs. And that means that PMPM is going to be quite high. And again, they would start putting significant barriers for the putting the drugs on the formulary that are new branded expensive drugs. So those are the two dynamics that I think are very important to consider. And these are regardless of who won the election. Well, with Joe Biden the Medicaid would be impacted based on his decision. Okay, so I'm done with my topic. Sorry, I am leaving so little time for the EU.
No worries. Thank you very much, I think, to both of you. I mean, I was also following very much into the details. I think there were a lot of important things, but I think as probably a kind of key takeaway, what I would take is basically, I think, whatever will happen, I think that the main task will be probably to decrease costs in order to, and that's probably the Biden-Harris plan, to also increase access at the same time, right? And I think this kind of maybe kind of combination with the current kind of plan, but also with the COVID-19 impact, I think might have obviously an important impact then on the potential situation across the globe. But I think we are taking here maybe the European Union as a kind of, let's say, proxy. So next slide, please. I think overall, I think what I would also take as a kind of, let's say, learning, what you also laid out, I think also early on in your presentation, I mean, what will happen? I mean, how are the kind of power shifts potentially within the Senate, and also what could the president basically finally do? But I think at the end of the day, I think what I also saw, and that's also what was already published a couple of, let's say, weeks or months ago, was that I think both the Republicans and also the Democrats are basically in favor of external reference pricing, right? So that might be maybe something which might anyway come up independent, I think, how, let's say, the kind of things, the discussions and all of those kind of things might really happen in the next couple of weeks and months. So I think maybe a kind of core question mark within the next couple of weeks might be more which kind of countries might be included in that reference basket for and by the US, right? I mean, this is just out of an article where I thought it might be just quite interesting to see, right? I mean, when you want to compare, we had those discussions a couple of years ago before the introduction of AMNOG in Germany, which kind of countries should be included there. And obviously there were as well, as here as well included there. I mean, I see Greece, for example, just taken out there, and a couple of others. But I think at the end of the day, the kind of economic power should be very similar in order to really make that comparable, right? So you could discuss maybe, from my perspective, maybe a bit obviously about Germany, about Switzerland, Austria, maybe Canada, but also a couple of other countries. But that's obviously just one perspective, right? Which is then the US, right? I mean, keeping in mind that, next slide, please, look. Keeping in mind, basically, when we now move over from that perspective from the US into Europe, I mean, it's also quite clear that basically the whole kind of Europe has any kind of external reference pricing already implemented since years, right? So there are different countries in the different country basket. There are different kind of adjustments being made. There are different kind of methods being used and utilized. But at the end of the day, I think what is also quite clear, the US is nowhere, at least so far, in the kind of basket in Europe. So maybe it's also the question, why should we care, right? Maybe next slide, look. I mean, this is just a kind of summary, and I just borrowed that out of a quite good paper out of 2013 by Rimuzat. So it might have changed over time in some of the countries, but I think it still gives a very good kind of picture. You see the different kind of countries with the abbreviation, and then you see as well the different kind of, just have a look on the additional countries column, right, on the very right-hand side where the US should basically appear. So the only one where I can really see that the US might have an impact is the big country where you see country of origin, and it goes to Luxembourg. Probably not yet such a kind of huge impact, right? But I think it's also quite clear to maybe ask that question. We have had those discussions with some players in the last couple of weeks, and I think when we came to that discussion on the US, I mean, most of them also quite honestly said, look, I mean, if we have very high prices in the US, why should we care about them, right? We're looking basically to get another kind of, let's say, influence on our prices because of low prices or because of other kind of agreement you have. I mean, if there's nothing really happening in the US, why should we really take them into account? I think what I heard now, I think also this evening by Anna and Karen, I think there might be different kind of impacts, right? Whether it is directly to the external reference pricing or maybe more indirectly, because I think they're also important components. I mean, if Medicaid and Medicare are suddenly being allowed to negotiate prices, this might obviously also have an impact. And I mean, Anna, I think I like also your kind of made in terms of ICER, right? I mean, if they would as well have something impact, maybe an external reference pricing would not clearly be needed as well by the US to have an impact on the overall global pricing. It might only have that kind of impact because suddenly Medicaid and Medicare could finally negotiate the prices. Next slide, please, Lutz. So obviously we don't have the final answer, right? And I mean, there are a couple of, let's say, calculations. We have had as well a couple of equations here on the table just to make some nice math. But I think at the end of the day, I think we could just as well do that verbally, I think, which is just much more powerful. So there are, I think, probably three kind of scenarios which might be maybe important. So I think before we start, and I think you had as well that on one of your slides, right? I mean, currently, I think at the end of the day, keep the FDA and the EMA maybe out of that equation, but at the end of the day, from a pricing perspective, from a let's say maximizing pricing perspective, I think currently the launch sequence is quite clear. America first, right? What we have in here. So is that really still true for launch sequence? Why does it really matter? Next slide, please, Lutz. I think why it matters, I think it's, I mean, just have a look on the data, right? Ultimately, the US trumps Europe in terms of revenue, always. I think that's quite clear. Even if you take, I mean, we have just on that slide, which was just taken out of the FBR website, around 18% of revenues coming out of the European top 5. Add the other 10 countries or 15 countries in there from out of Europe, it doesn't really change a lot of the picture, right? At the end of the day, the vast majority and the big majority, over 50% of the revenues are coming out of the US. If this will still be true, once the prices might be lowered, it's maybe a question mark, right? Because ultimately, and we will, I think, see that maybe around those scenarios which will come up, is, I mean, if also industry might adapt, that kind of proportion might not shift, right? Maybe the kind of level might shift a bit, lower or upper. That's maybe the question as well. Next slide, please. So another question, why maybe the question mark is still important when we just simply say, would the US really still be the kind of first launch country, right? Is that we still have a couple of countries, but at least with some few examples here, I mean, we have also a bit of a higher prices being achieved as well, at least around launch, right? I mean, that's also a big difference, right? I mean, launch price in Europe, the price just goes down. I think in the US, you have still the kind of opportunities as well where the price, at least up to now, right, go up. So that might as well be maybe a question why maybe not Germany, or why maybe, I think you see here as well, Canada or Belgium, interestingly for me when I saw that as well, that those prices might have been quite high. Next slide, please. So, I mean, if we just, let's say, go through a couple of scenarios, and those were the ones we have also built up out of, let's say, also discussions with different payers across the last couple of weeks and months, because I think that kind of discussion on the external reference pricing was also already starting when Trump was basically putting that into the discussion, right? So if we assume the launch sequence would still be that America would be first, right? And then we would just assume that over time, and I think that might not take a lot of time, other countries might as well adapt to that kind of external reference pricing and potentially at least have the US as well on the radar screen in the negotiations, right? I mean, if we still assume that we might get high prices in the US, independent, you know, what ICER might look like, how the negotiations might go as well in terms of Medicare, Medicaid, I think at the end of the day, there might be only a few countries being available to also pay such kind of high prices. I mean, currently, also given COVID and the kind of budget impacts, et cetera, and the kind of money flow, what we see also across Europe and across the globe, I think there might be maybe limited countries, maybe like Germany. I just put as well Canada in there, because I also believe that they could as well maybe afford those. And then there's a bit of a picture like an emptiness, right? What else then? I mean, we have countries like, I mean, I really like our friends from Italy and Spain, but given the kind of budget situation currently, this might be a big issue. Not even going to other kind of countries in more the eastern part of Europe, but also in other parts of the globe, maybe in some parts of Asia, also in South America. That's, I think, a quite important scenario to consider, that I think at the end of the day, I think there might be then even fewer countries being available around the early launch times, which might then be also available to also pay the high prices early on. Next slide, please. One back, please. So there might also be another kind of, let's say, scenario here, right? We could also assume, because at the end of the day, I mean, what you have also shown in your slide, I mean, if there's no external reference price country currently available at launch in the US, it might be maybe even more complicated, right, to get an attractive price. If we turn a bit the kind of picture, we just say, look, we have free pricing in Germany at launch. We have free pricing in the UK. Forget about NICE, because that's just coming afterwards, right? There is free pricing available. Those are the two countries. And suddenly, if you have, for example, a kind of HU program in France with also quite high price, you suddenly have potentially 3 countries being available as an external reference price in the basket in the US. And you could really set a quite high price in those 3 countries first, and then also in the US, which would anyway, again, lead probably to the kind of scenario that there might be maybe the product available, again, especially in this case, maybe more in Germany and in France because of the ICU program, in the UK probably just because of maybe if it's cancer product around the Cancer Drug Fund, but I think then it might as well be available in the US because there might be kind of references for that kind of higher price, assuming that those prices also in Europe might have then been chosen, those might as well meet the high US prices. It might be very difficult to, let's say, get access in a lot of the other countries. So there might be even a further kind of time gap. We see that already, right, happening in a lot of countries, but I think that time gap might even be increased over time. So this would also mean that obviously those patients in other countries might have later access because of that kind of program. And finally, I think before we come, I think to the questions, let's next slide. I think ultimately there could be obviously a downward spiral upcoming for the prices around the world. I think independent, and we have just assumed here that the product would still be first launched in the US. I mean, obviously we could just assume that the prices could be launched a bit higher. You could take those 2 scenarios we have just taken out there as a kind of example. Independent of that, I think there might be high price in the US. And then once you come into the kind of, let's say, spiral that you get assessed and being negotiated, for example, in Europe, you suddenly need to give anyway kind of discounts. Because of the external reference pricing and or that kind of negotiation opportunity for Medicare, Medicaid, and I think you have as well said that this might as well be negotiated for, let's say, prices happening or pricing events that are happening in the past, right? Also, the US could adapt to those prices, which would obviously then have the kind of spiral that also the price in the US is going down. And I'm pretty much sure there might not be a lot of time basically falling down before some of the other countries in Europe might also have the US as a reference price in there. So then you're already finally in that kind of downward price spiral, which I think is a quite likely event in the next couple of years. I think that's the kind of scenarios and the kind of scenario we have put together also out of discussion with different payers across Europe, where we thought this might be a quite likely scenario. And now I think I think we're already at the last slide here, so open for any kind of questions and discussions. Also, obviously, Karen, Anna, I mean, your kind of thoughts on the kind of scenarios we've just presented.
Thanks, Stefan. And I think one thing that just to keep in mind when we're talking about external reference pricing is that at least the proposals that exist right now are for a very limited set of new drugs. So only maybe the most expensive biologics, the ones with no competition. So, you know, both the Trump and the Biden proposal are for that very small set. You know, there are people on the more progressive side of things who want to push for more broad reference pricing. But at the moment, I think probably we would put our toes in the water and try it just for maybe, you know, 5% of the new drugs, not all of them.
Got you. Which is also an important point, absolutely. So I think that's maybe as well something to consider. And I think everybody would then as well need to get a kind of feeling, right? I mean, which kind of product those would really be. I fully agree with that. Yeah, good point.
Yeah, and how do we define that, right? Because in both of the plans, they say, you know, the novel drugs. What does that mean? Yeah. How do you decide what is? So that would be another question that comes up. Yeah.
Wonderful. Anna, any comments of your side?
Well, what I was thinking is that if ICER in fact is chosen to be that external board type of agency, ICER, when they do the assessment at the end of their budget impact analysis, they do say their recommendations on a type of a discount that would be required to make a product cost effective. And if ICER in fact is given authority to become the agency that where that output is to be seriously considered by others, wouldn't that type of a public report with a publicly suggested discounts potentially can be used by other health technology assessments? Maybe not UK, who's not choosing anybody, but there are others that heavily use other HTAs. Yes, maybe I'm not discussing EU5 specifically, but beyond EU5, many countries in Europe and countries in Latin America, I've experienced that when we've supported submissions in Mexico and Brazil, they pick up Canadian assessments, UK assessments, other countries pick up those. Would that mean that if US is first, and by the time, let's say they are launching, let's say Canada is reviewing and there is US ICER report already, would they use that in their favor to say, hey, that's what it was, and we're going to reference that? I mean, Italy and Spain reports often use NICE, previously published reports. Does that mean that they also going to start using this US ICER report and their recommendations when they bluntly say, oh, a 70% discount would be needed to get to cost effectiveness? And would that then change how they negotiate their pricing? It's obviously up in the air, but I do think that this is a scenario we should consider.
Wonderful. Okay, let's move up to the question and answers here. We got plenty of questions now by the audience. Wonderful, thank you, the audience, for all these good questions. So the first one I want to raise is, if the external reference pricing is implemented, in your opinion, which country would be the most positioned? So Karen, would you start, and then Anna, and then Stefan?
I think I'm going to hand that one over to Stefan because I think he's probably gotten into that the most.
Oh, so you call the audience, Chuck? Okay. Okay. Stefan.
Yeah, I mean, I think I understand the question. I mean, to basically, or let's put the other way around. I think the question is probably asked which kind of countries would be included in the external reference basket, right?
Yes.
And I think for the US, I mean, as already said earlier, I think what I would hope for if something like that would really happen is that at least kind of comparable from an economics perspective, I think comparable countries would be included. I think, you could take their countries like, I think, maybe some even Asian countries, maybe Japan, even though that we all know that the price in Japan are not that favorable for the US, I think. But I think there might be countries, obviously, like Germany, I think like Switzerland, like Austria, maybe also like smaller countries in like maybe the Netherlands and Norway or Sweden in Europe. But also, I think just because of the geographic kind of closeness, I think obviously also Canada would be probably included there. I think it would be probably even more interesting, at least from my side, right, coming out of the European view, is, I mean, how also the European countries would adapt to that kind of change, right? Because suddenly there might also be not only the US being interesting to be included in the basket, but also maybe other countries, such as Canada maybe. And we know that in some European countries, we also have countries included in the basket beyond the EU countries there, right? So I think there might be even some kind of movement suddenly coming up in that kind of area as well, because the US as a kind of, let's say, really big kind of, let's say, elephant at the end of the day, right, would come as well and get into that game as well.
Wonderful. Anna?
Yeah, I think I agree with Stefan. I think Germany and Canada and some of the Nordic countries, I think they're kind of first on the list that I think to be considered. Yeah.
Yeah, Germany also has a strong price negotiation part. So, I mean, you also want to choose that countries, you know, that are tough negotiators, right? So, um, Karen, anything to add from your side?
No, I think we can move on.
Okay. Then we just get the next question, which is, are there any consideration in the US to make the supply chain more efficient? For example, reduce power of PBMs.
PBMs. Yes, everyone wants to get rid of PBMs because we have a lot of players in between, and they all get a cut. And and they don't seem to be, the official role is they're supposed to negotiate great rates for the drugs, but it obviously seems like they are failing at that while getting the cut. The drug prices are not getting lower. So I think they're getting a lot of heat recently, and I would think they will be not in a good place next year if Biden is successful. I think that they're definitely going to be cutting out, you know, the mid players that get a cut in that price.
Wonderful, thank you. Let's move to the next question.
I mean, yeah, there's going to be this pressure. Like, if insurance companies need to provide lower cost plans, then they're going to look at every part of the process and see where they can squeeze. So I think that would be an obvious place.
Okay, wonderful. So the next question is, do you believe the new administration may consider support, again in brackets, the development of innovative access agreements as performance-based or risk-share agreements?
These already exist, okay? These already are in existence, the value-based pricing and the value-based agreement. These are, they picked up a few years ago quite a bit, you know, but now what exists is, and I don't know if it's a European question, what exists now, and it's quite popular, is it's called prior authorization, and that authorization is limited for a certain amount. So prior authorization means that the physician needs to fill out a lot of forms to justify giving this medication and showing proof that that patient in fact has the proper diagnosis or failed on proper, you know, several treatments. And then the authorization is only given for a limited time. It could be 3 months, it could be 6 months. And then after that, there is a reauthorization process. So that is already exists and is quite popular. And I am sure that that will continue. I'm not seeing this going away at all.
And then we have a next question. So when we're talking about that external price bucket there, external reference price, could we consider a temporary price? I mean, that was your idea, Stefan, with the first year price in MNOG and the ATU price in France. So is that just a temporary price than the final one?
Yeah, I mean, at the end of the day, I think it's also important to keep in mind, I think some of those things might be also a bit theoretical at the moment, right? I mean, keep in mind that obviously before we go into the market access pricing discussions and declarations or negotiations, we also have the regulatory pathway, right? And a lot of times they're not really synchronized, right, between the FDA and the EMA. So I think keeping in mind, obviously, also that this could be something where the industry could have, let's say how they could also influence a bit their kind of, let's say, strategic moves. I mean, obviously, important point here, what was made, I mean, if there is I would not call it temporary price, but let's call it a kind of a price, a launch price, which might change over time. And we know that, you know, those things could change in France. Keeping also in mind here, I mean, that price might be holding true for a while, maybe even more than a year or 2 years, depending a bit how, let's call it, strong you are in the price negotiation, right? So you suddenly have a quite high price, the same in the UK. And then, you know, you could also think of when to launch in Germany, right? It's not a must that you basically launch, for example, that scenario what ICE, let's say, suggested that you go in the UK, France, and Germany at the same time, right? If you start in the UK and in France with the ATU program, let's say 6, 9, 12 months before Germany, and you have maybe even synchronized a bit the kind of regulatory pathway, the way you could really do it, or the kind of launch time for the US, then you suddenly have potentially a kind of, let's say, 1, 2, 2.5 years of a time frame where you can really optimize or maximize your price, right? Before at least the kind of European prices are going down, because Germany might start with that because of the price negotiation. Then France might as well follow, because you would need to agree, because suddenly you don't have the product suddenly available via the ATU. And also maybe in the UK, you might have NICE suddenly coming in, right? So then you have that kind of price drop. But I think it's also then a kind of question and game and how to optimize your price over time, right? That's also, I think, when I said there might be emptiness, let's say, before the product might be also available in other parts of Europe or across the globe, right? So there might be maybe a few countries at the early beginning, and once the price is going down, we see that now, right? It's just then that the game might change a bit, right? Because suddenly the US is also part of that game. It is not an independent kind of game, right? So it's not Champions League and the first league in football here, right? Then you suddenly have everybody in the same league. So I think that's a bit of the question. So I mean, at the end of the day, I would just say prices are not fixed, right? I mean, they are as well moving over time, and that's, I think, something to see as well, how that could also be managed. I mean, at least from an industry perspective, I would take that as well.
Yeah, you raised a good point, and there's another question actually. So looking at that international reference pricing plans, how often will this process take place if the marketing authorization holders have the option to work their way around that by targeting the US as the first country for market access? And will this potentially delay the market access in the European countries?
Yeah, I mean, how often that might really happen? I think that's, I mean, as we just said, I think Karen made a very good point. It might not, let's say, affect all of the price, all of the drugs in the US as well. I mean, how many or how much of those kind of times might it also happen in general? I mean, as said, I think it depends a lot of, or let's say, on a lot of factors. I mean, one thing is the regulatory pathway. I think the other thing is, I mean, we're just speaking about the product without competition, right? What is happening is suddenly there is another kind of product coming up in the market. Then you anyway have a kind of direct price competition as well coming up. What if there might be other kind of things happening because of, I don't know, other kind of clinical trial data coming up, etc., right? I mean, again, I mean, this is just one, let's say, equation of the whole kind of pricing and the optimization for your price, right? I don't like the word maximize price. I think it's more optimizing it, right? So I think that's all of those kind of factors which are important keeping in mind. I mean, you can manage some of those as an industry, but I think also from the other perspective, right? I think payers, I think in the US, I think especially private payers are very much used to that. And I think also European payers are more and more going to that direction, that they're also trying to manage those prices, right? It's not just negotiate that, you know, once and then everything is done. I think it's really more that kind of managing the whole kind of market, and the market, or let's say to that market, also the pricing is obviously part of that.
Wonderful. Anything to add, Karen?
I would just, yeah, I mean, I'd say maybe just as a final thought about it, is probably, you know, there's a lot of things that could happen, and I think probably none of them are going to happen in the next 12 months. So I think, well, yeah, there will be time to kind of think about some of this and strategize, because certainly, you know, this is a president who's coming in with some very big problems to work on first. And I think that, you know, part one of healthcare is going to be certainly, you know, pandemic and dealing with some of the major issues. And I suspect that prescription drug pricing, although it's a very important topic, probably is going to move a little bit further out. So I wouldn't panic that things are going to change, you know, January 21st or something.
No, exactly. Very good point.
I would like to, though, disagree a little bit on that, okay? Although in general, of course, this is correct. I think that the pressure on the drugs that are branded and will be launching in the next 12 months would be as high as it ever been, higher, potentially higher, due to this COVID influence and due to the fact that we do have Biden, even if he's not able to pass any legislature through. because I think it would embolden the payers, as a governmental and private, to put more barriers, to push back more. And there are other ways they can push back without just necessary pricing. As I said, prior authorization, they do tiers, they do all kinds of pushing the costs and limiting the population. So there will be a pressure on negotiations, and definitely a very big pressure for price increases. Ability for any manufacturer to increase any prices next year would be very tough to do that. And all US, we're used to price increases. This is a concept that's just truly US thing, where the first price is just a start and then it goes up, versus we're not used to that in Europe, where everything goes down.
That's true. Yeah. So there's the law, and then there's kind of that competitive, market pressure, which absolutely is going to be very big.
Wonderful. That was almost the answer for the next question, but a potentially reduced list price will impact the middleman, like the PBMs, right? Does that change the reimbursement dynamics and the negotiation with these entities? Definitely yes. So there will be a high pressure of that. Okay, that was a wonderful closing remark, actually, Anna. Thank you for that. Now, as we said, that slides will be provided afterwards, and also the record of that webinar. And please check out our website. That's www.marketaccess-pricingstrategy.de. Here in Germany, for the recording of the webinar, you also can find that on the webpage. And check out the story of the purple squirrel economics here at www.purplesquirreleconomics.com in the US. Thank you, Karen and Anna, for this wonderful presentation tonight, and that insights, or tonight in Germany, it's your afternoon, and these wonderful insight in the US politics and the US health economics. Thank you.
Thank you. Thank you very much.
And then I just want to make some advertisement for our next webinar, which is the end of COVID-19 due to the vaccine. Stefan, when do we have our lives back? That will be like our Christmas session here for the webinar here. So be prepared. Check out our LinkedIn page. There will be probably some surprise for you there attached. So thank you all again for the wonderful presentation. Thank you, audience, for listening and stay so long here. We even get the most longest webinar we had in history of these webinar series. And we got a lot of feedback here where you all said that was a wonderful and very informative presentation. Thank you. Stay all healthy. Fight the COVID-19 virus, and take care. Good night and good luck.
Thank you. Thank you, Karen. Thank you, Anna. Thank you all for listening. Bye-bye.
Bye.